Hello, everyone. In case you don't know who I am just yet, I'm Jessica Griffith. I am the Colorado chapter manager. So happy to have you guys here. Welcome. It is always my pleasure to get to work with some of the very best of our business partners. They are always here to support our chapter and our events, and for that, we are so incredibly grateful. I know it's hard right now in this virtual world to make those connections with our sponsors, but I would highly encourage you because they have a wealth of knowledge that they are always so happy to share with you, and they are always generous with their time and their expertise. With that, I do want to take a minute to just name out our sponsors and give them a big shout out here. First off, our plan sponsors, Aspirian Health Resources, BC Services, Collection Center Inc., Continuum, Patient Co., EFS Group, PFC USA, Revenue Enterprises, TransUnion Healthcare, and Western Healthcare Alliance. Our gold level sponsors, AccuReg, Argos Health, BKD CPAs and Advisors, Cedar, Centauri Health Solutions, Commerce Bank, our Commerce Healthcare, Eide Bailly. Our speakers today, Guidehouse, Healthcare IP, Healthcare Resource Group, KeyBank, Plant Moran. And our silver sponsors, Colorado Health Facilities Authority, Credit Services Company, Paul Render, Killian Health, Heath and Lyman, Nuance, Olive, RMMI, and Extend Healthcare. Just a huge shout out to all of our business partners. We appreciate you so much. And with that, I'm going to bring up, again, one of our great gold sponsors, Kimberly Zeltzer, to introduce our speaker.
Hi, welcome to the No Surprises Act session. I'd like to introduce our next speaker, David Brueggeman. David is a director of the payer and provider practice at Guidehouse and has 13 years of experience providing analysis and strategic insights to payer, provider, and governmental organizations. He specializes in enterprise strategic planning, network and operational strategies, and policy evaluation. David previously worked at CareSource as a director of medical economics, where he was responsible for corporate financial analysis, actuarial, financial information management, provider contracting analysis, and medical economics teams. David, I'll pass it over to you.
Thank you so much. And first, hello everyone, happy Friday. My name is David Brueggeman, and I have the distinct pleasure of presenting you information regarding the No Surprises Act. As much as I would have loved to be presenting this information to you in person, I applaud our HFMA organizers' decision to continue to monitor and respond to the COVID activities. I would also like to say thank you to each of you in this virtual chat, as you're playing a role in our nation's response to this, I guess, hopefully once in a lifetime pandemic. While every system may have, your carefully crafted mission statement, in the end, we're all in the business of helping people. And it's a real privilege to be in this presentation with the individuals who are spending their lives supporting that goal. So let's go ahead and dive in and start talking a little bit about our goal. So I always like to start these sessions with a review of what we think of as the constellation of transparency-related regulations. HHS, in conjunction with several other federal agencies, has been making concerted effort to increase the ability of end users to access information about their care and, of course, the price of that care. Most of us are very familiar with the hospital price transparency rule after going through, we'll call it the compliance gauntlet at the beginning of this year. And although the process, I'm sure we've all seen the articles, although the process has really been plagued with dubious information being put out by different hospitals in their files, and there's been some fumbles on the formatting instructions provided by CMS, compliance levels across the country are beginning to increase. So, CMS continues to send out letters to the non-compliant hospitals, which we will anticipate will lead to even greater information availability. And another catalyst that we sort of see coming down the pipeline is that payer machine readable file on 7/1/2022. which will provide all of the services that the payer pays for in a machine readable file as well. So given the increased penalties that payers will face, we at Guidehouse really expect a high level of compliance from the payer side, which may lead to some of those hospitals that are, we'll call it, holding their information tightly to chest for competitive reasons to sort of reconsider their decisions. The data interoperability rule is another piece of this proverbial pie. The shuttling of information between payers and third parties will remove some of those payer powers, if you will, in the fact that they hold the data within their system and don't necessarily share it well. And then finally, really, the Consolidated Appropriations Act is the next component that we'll be talking through, which is really the genesis of much of what we're working on. Now, I will note as part of this that the advanced DOB is now delayed indefinitely pending further rulemaking. All right, let's go to the next slide. So looking at the surprise billing legislation timeline, we're looking at really a brief history of the genesis of the act. We started with ERISA, which many of us are familiar with. And then, of course, following on that was the Emergency Medical Treatment Act that really required hospitals to treat all patients that show up at the emergency room, regardless of ability to pay. The Affordable Care Act layered additional requirements on top of that, specifically that emergency services were covered by at in-network rates, but the network could still balance bill individuals in terms of services being provided. The No Surprises Act was introduced a while ago, but it has continued to sort of bounce around in the legislative agenda until finally it sort of made it over the finish line as part of the Consolidated Appropriations Act, which then President Trump signed over the holiday break in 2020. So since then, we've seen a couple of releases of rules to implement those regulations, and that has been a really exciting process. Although I will tell you, it does eat into my 4th of July weekend when they released them on the Friday before. So that was very, very kind of them. So then as we go to the next slide here, the No Surprises Act protects patients in 3 specific situations. So emergency services that are provided by out-of-network providers in an in-network or out-of-network facility, non-emergency services provided by an out-of-network provider at an in-network facility, and then of course air ambulance providers. And it applies to both group and individual health plans. The cost shares and accumulators that are limited to in-network rates for these services. And of course, many states have had similar bills in the past, including the one you all are familiar with, which is HB 19-1174 in Colorado. So we'll talk about some of those similarities and differences in the bills later in this conversation. And then, of course, the last thing that I would really call out here is that CMS, which if any of you are the type of folks to read these rules, is notorious for underestimating costs in implementation, but they have identified this as a roughly $6 billion implementation cost for the entire system. So a significant amount of dollars that will be needed by both the payers and the providers to execute on this. So this was all driven by the identification of a significant issue, which of course is these quote surprise bills. Based on several studies, it's estimated that about 30% of patients with private insurance were receiving these surprise bills. I think, as we know, that really had headline grabbing dollars associated with them. Local newscasters delighting in exposing these particular situations. The challenge was, of course, those ignore the actual patient collectability aspects of those balances, any of the context that really surrounds those particular numbers, that of course our revenue cycle professionals that we've got here in the conference room with us here, you all will know those challenges. Other studies address the ability of Americans to pay for the unexpected expenses, which ultimately drove some of the process initiation costs we'll talk about later in this presentation. They really sort of try to base it on what the expectation of ability to pay in a surprise situation. So going on to the next slide here, really within that CAA, the three main components that apply to the healthcare system was the No Surprises Act. There's a comparison tool requirement, and then of course the advanced EOB. And the advanced EOB is sort of delayed indefinitely while further rulemaking comes out. I won't talk too much about that cost comparison tool, but the one thing I would encourage you to think about is the fact that yet another set of prices will be available to consumers. And as you think about communication strategies, digital strategies, if those prices are not aligned with the prices output by your patient estimation systems, it will continue to increase confusion on what the actual price of the service might be. So highly encourage everyone to just kind of put that in their minds as part of the strategy. Of course, as in any good regulation, the promulgation of rules supporting that regulation is a path. And in this case, interestingly, CMS, HHS, and the other two tri-agencies involved in this have already stated we're not going to be able to get all the rules out in time to meet these regulation requirements. So some challenges there, obviously. Unfortunately, they're still expecting plans and providers to adhere to the regulations, even without the supporting rules for those that are expected after 2022. So as we think about those 2022 regulations that will be coming, I would encourage anyone who's on a managed care team on this call, or if getting this information back to your managed care team, that you start thinking about those prohibitions, gag clauses for the plan years moving forward. I think that's an important piece to be thinking about in your negotiation approach today. Similarly, we're expecting more activity on the confirmation of whether or not a physician is in network, because there are significant penalties associated with provider directories for payers. So if the information in the provider directory is wrong, then it must be paid at an in-network rate. Okay, let's dive into some of these industry impacts and some very specifics within this. So for those services that are provided by out-of-network providers, HHS has divorced the amount utilized for cost sharing, meaning copay, coinsurance, et cetera, from the amount of dollars that will be transferred in between the payer and provider. And this is a fairly significant deviation from the past. There's been waterfall logic that's been defined for each of these amounts. In both cases, the starting point is an all-payer model agreement, which of course is only applicable in a state or two. When that doesn't exist, the next step is to really go to an amount determined by state law. We'll talk about this when we compare the state and federal rules, but the applicability of the current state law is unclear for this step as of this moment. The next step is really around where those two amounts diverge. So from the cost sharing calculation, a specific calculation defining the median contract rate for the plan is used. And we don't really go into that calculation, but it has multiple steps, and it really depends on the amount of information that is available for that market, whether it's a local geography, a state geography, or a national geography. And there's requirements of the number of services provided within each one of those. So that last calculation is really known as the QPA. So we're, as we're thinking about things that we need to add to our lexicons in our kind of acronym lists, if you will, QPA is a really important one in this process. Qualified payment. So on the actual payment side, we'll have further discussions and the details about how those negotiations will occur momentarily. But it's also important for our managed care folks on the call is that issuers cannot require prior authorizations for OBGYN services or emergency services. And the new rule also removes the ability for payers to deny coverage of emergency services based on the final diagnosis code. So this is something we saw fairly frequently from payers, especially the large payers within our market. And we knew that that was a pretty significant challenge. So, HHS called it out that we are aware that this is happening and this should not be happening. An expansion of the emergency services definition to include post-stabilization services, except when the emergency physician determines that the patient can travel using non-medical transportation within a reasonable travel distance with patient consent. So there's a couple of different benchmarks and gates in that process. The rule contains definitions around the reasonable travel distance, but we see a bigger impact from the requirements from the non-medical transportation to be able to be utilized. So an example here is, currently a lot of times you are allowed to transport from utilize an ambulance. This requirement does not now have that emergency transportation requirement. So finally, the denial or payment amount for out-of-network services is to be sent within 30 days to receive the clean claim, because that is an important trigger, which we'll talk about here in a little bit, around some of the timeframes that are associated with the processes for this news process. So just in case we do have any air ambulance providers in the room, and I'm not sure that we do, but just in case, we would recommend that they consider thinking about a full payer relationship program. It is now going to be increasingly difficult to get to that bill charge level. And so it's a really important part of the process for air ambulance service providers. For out-of-network elective procedures, there are notice and consent requirements with certain exceptions. We find most of our clients, based on the engagements that we've been working with, in this space, that they have processes in place for this. It's really around revamping those processes to include the additional information that's required under these rules. So the notices, the consent forms, and all the other minutiae that goes along with it. The non-participating providers must also bill payers to comply with the rule and must not depend on the patient to initiate the process, which is once again a patient-friendly stance. CMS is really expected to provide those model disclosures for the patient protections on balance billing, which will need to be integrated in the existing process. This is actually in addition to any state required disclosures. So once again, an expansion of the information that will be required to be displayed. Finally, a lack of adherence to these rules does open up providers to the potential enforcement actions from HHS. So let's dive a little bit on that independent dispute resolution process, which is something that can be utilized if there's an inability to agree to an out-of-network rate. So one of the major challenges of this process will be these incredibly strictly defined timelines. Once the original payment or the denial notice is received by the provider, they have a 30 business day window to initiate an open negotiation process. While this may have happened in the past in more informal settings, there are required notices under the new rule, which have to be taken into consideration. Should that agreeable amount not be identified during the open negotiation process, then both the payer and the provider must wait out the full 30 business days before initiating the IDR process. The IDR process has a 4 business day window in which it must be opened by submitting the appropriate notifications to the Secretary of HHS. They're encouraging the use of the IDR portal, which has just recently been opened. And then, of course, notification to the counterparty that the process is moving forward. The arbitrator in the process is also known as, we'll call it the IDR entity, and it will be selected either by the consensus of both parties, meaning the payer and provider can agree to use a specific IDR entity, or if they cannot choose, then HHS will select a IDR entity for this particular situation. The next step is a 10 business day sort of time period for both parties to submit final offers and supporting documentation. The IDR entity will select one of the two as the payment amount in a baseball style arbitration, meaning you only select one or the other. There's no halfway in betweens in this. Both parties must accept this payment amount as binding, and any net payment change must be remitted in those next 30 days. It's really important to think about what are those changes that may occur in that payment amount. So effectively, starting from that QPA, and that's what the instructions are to the IDR entities, start from the QPA and determine what is closest to that QPA, and then what has the best information supporting it to be either higher or lower than that QPA. We provided another slide here that just goes into a little bit more granularity. I'm not going to review it on this call, but once again, if you're really trying to dig into the details on this, we've got that for you. I do want to make one quick note on the IDR entities. It's really important for both payers and providers to identify any relationships that they have with these entities. There's a requirement around identifying conflicts of interest. In our client projects, we've really been expanding those disclosure requirements for employees to making sure that information gets transferred to the appropriate department that is making the selection of the IDR entities. So it's really an important piece of this puzzle, is understanding those relationships that individuals within your organization may have with any of these entities. All right, the next thing I'd like to go through is our good faith estimate process, which is really for, I guess the accompanied selected dispute resolution process, which is what SDR stands for. Yet another item for our acronym list and lexicon. This will apply in 3 situations. So uninsured, insured but not intending to submit a claim, and or shopping. I mean, they can request this just sort of out of the blue, even if they're not actually having a scheduled procedure in place. And then short-term limited disability plans. These estimates must be provided in these incredibly short turnaround times that are going to require coordination in between multiple departments and potentially even multiple entities. If you think about anesthesiologists and PT on follow-up, those kind of pieces. First, the provider must disclose the ability to get the estimate. So you have to add to your wallboard of disclosure requirements this particular information. Then the patient activates the process by making a request. This starts a limited time frame in which expected services, diagnosis codes must be determined, and then prices must be developed for those services and diagnosis codes. Then other providers for the episode must be identified, and then they must in turn provide their estimates. So we're working with clients to really choreograph this symphony of activities to provide this in this extremely limited time frame. To prevent duplication of primary, or in the rules, they call it a convening healthcare provider is identified, who is really the responsible entity for gathering all that information. Now, HHS did acknowledge, and we're seeing that maybe the softer side of Sears here, HHS did acknowledge the challenges of this inter-provider coordination. and has extended the enforcement deadline for that particular coordination component until 1/1/23. So that is one other sort of delay that came out in the interim rules that were released actually last Thursday. The accuracy of these estimates is incredibly important, and we'll discuss why here on the next slide. Okay, so now into that SDR process. So should that final bill to the patient exceed the good faith estimate by $400 or more, and that $400 is really based on those studies as to how much money the average American can pay in a emergency situation, they can pay, the patient can pay $25 to initiate a selective dispute resolution process. To activate the process, the individual has 120 days from when they receive that bill to notify the Secretary of HHS through a couple of different methodologies. There's a paper, via regular mail, via email, or what they are trying to drive everyone to is the IDR portal, so they can initiate that dispute. The process is intended only to require activity from the patient at the beginning of the process. So really the patient initiates, and then the patient is expected to be relatively hands-off. Now, there is provisions that allow patient advocacy groups and so on and so forth to represent patients through this process. But that being said, the process is really designed for the patient to submit their bill, the good faith estimate, any other information they'd like to, and kind of push that off and be done with it. And once again, that's for a 25, accompanied by that $25 fee. The burden of proof really falls on the provider in this process. So the government pays for the SDR process, and we'll be contracting with several entities, which will be assigned. But once notified of that SDR initiation, the provider has 10 business days, yet again, to respond with documentation. And that documentation must support why the services that were not contained in the good faith estimate were, quote, unforeseen at the time of scheduling. HHS has been very careful to indicate that the unforeseen definition will be much narrower and closer to sort of unknowable at the time of scheduling than medically necessary, which is the standard that many of us are sort of used to. The SDR entity will have about 30 business days to make a determination. And if there is a determination made that any amount if that bill is ultimately lowered through that determination, then of course it is again lowered by $25. So effectively, the provider is paying that $25 initiation fee. Okay. So let's talk a little bit about the Colorado rule versus the federal rule, and starting with the applicability of rules to certain payers. So as we all know, with the CODOI print on the card, that then subjects it to the Colorado rule. It has to be a state regulated plan, but the state regulation does not apply to self-insured plans that are covered by ERISA. Whereas the federal rule is comprehensive group individual health plans, including those self-funded plans. While they both share similar claim types for emergency services performed at an out-of-network provider and services performed by an out-of-network provider at an in-network facility, they differ in ambulance types. So the Colorado rule has rules around the ground ambulances, and the federal rule has rules around the area ambulance services. As you can see in our chart, the timelines are also significantly varied, with significantly more time allotted to the Colorado rule compared to the federal rule. In two instances, the Act specifically defers to the requirements of applicable state surprise billing laws. So to determine the total payment amount from which the patient cost sharing is calculated. So that's that step before calculating the PPA. And as the arbitration process to resolve the parties' dispute instead of the federal IDR process. So besides those two areas, providers and insurers should be prepared to sort of account for both the federal and state act in this particular situation. The No Surprises Act also does not include a preemption clause, meaning that the new federal law does not replace or supersede any existing state laws, which of course creates a lot of complication and confusion as those two get matched up. So we look for additional information in terms of how those will connect in the future. Really, the payment rules, of course, differ. So, we talked a little bit about the federal rule on the right here, how the waterfall works. But if we look at the Colorado rule, I'm sure many of you are familiar with this. It's unclear if that will actually sort of step in as that second line within the federal rule. So we'll continue on that. So let's kind of step back a little bit. I know I appreciate everyone sort of sticking with me through this rule overview, but let's get into some of the questions we're working with our clients to solve. We're starting in the revenue cycle arena here. I also have the next slide will really be on the managed care and the strategy side, but starting in revenue cycle, from a scheduling perspective, do you have enough lead time to allow the liability estimates to come through? And how comfortable are you with your referral process to validate that in-network and out-of-network process for non-employed providers? And are provider enrollment checks performed to ensure providers are in-network and actually contracted with the payers? As we think about billing, do you have policies and processes for potentially adjusting off or reviewing those patient liabilities that fall outside of that good faith threshold set by the government? What type of processes do you have in place to monitor denials, specifically out of network, to ensure that patient would not be improperly bounced back? And then as we look at price estimates, how are you currently working through your COP processes? Utilizing how are you creating those price estimates today? Are you utilizing MyChart if you're on Epic? Are you using another capability to do so? And then how does that sync back to the pricing that you're displaying everywhere else, from your price transparency machine readable files, your shoppable services file, what will be the pair shoppable services files, and price estimator tools? And are you comfortable with your processes to update those contract builds within your system? Then as we go to providers, how are those non-employed positions contracted with your payers? And what is your payer enrollment process for employed positions? And do you hold those claims so that way you're not accidentally subjecting some of these services to a no surprises process, as opposed to waiting for those to be released through the standard in-network process? And then really going into our managed care and strategic considerations, we'll start with case pricing. So does your negotiating team have the appropriate support structures to meet these incredibly fast turnaround times? Do they have the clinical connections they need to understand what those diagnosis and procedure codes are going to be? Do they have the information about how that will ultimately price through grouping logics or any other approaches they take? And are they empowered to make those decisions at the appropriate level, because this is such a rapid process? We think about that contract negotiations. Do you know where your organization stands relative to your market median for that geography? Are your prices is in an advantageous position from a pricing perspective? And does that change the equation of how the payer treats you? Do these rules change your approach to the terminations? So how are you going to go into those termination negotiations, knowing that there is a process for out-of-network payments? And how does this change your relationship with wrap networks? Effectively, this becomes a sort of wrap network, if you will, in the process, and that can change your approach. So, and then on the vertical integration side, bringing this up a level, does this change your service line strategies? If you look at providers in your area, is this significantly changing their profitability? Is it an opportunity for you to enter into partnership or mergers and acquisition conversations? We certainly have clients who are thinking in that direction. How does this increase the need for contracting coordination with the non-owned provider groups? How are you transmitting that information back and forth about what payers they are engaged with? And then stepping back up yet another level for our system strategies, do these rules factor into the equation for starting or continuing provider-sponsored health plan within your organization? There's a significant amount of expense that's being loaded onto these provider-sponsored health plans in compliance with the rule, but it also changes the ability to have a larger network because once again, these out-of-network capabilities are in place. And how does this impact your employees' plan administration? So going back to the HR side, does this change how you approach your benefit design for your employee plans? So a couple of considerations that we've talked about here. I want to give a little bit of time. I know I've been taking a lot of air here, so I do want to give a little time for some questions and answers, but hopefully you've been able to stay with me through this review of the rule and talking through some of the strategies associated with it.
Thanks so much, David. Well, we wait and see if we get any questions come through here. If you have a question, feel free to just pop that into the chat or in the Q&A box. If you want to ask it live, you can raise your hand and we'll get that question out there. But thank you so much for your time. I think you touched on this. We did have one question earlier on in the presentation, but air ambulance services are explicitly included, but will this apply to ground ambulance providers as well if the company is a private third party not owned by the hospital?
Yeah, so it does not apply to ground ambulances. It was a specific exclusion from the federal rule. So I think that's where we were sort of talking about those differences in between the state and federal rule. I do think that there have been other conversations about where does that ground ambulance play in. I don't know if it was just a great ground ambulance lobbying effort that got them excluded from this particular rule, but certainly a great opportunity for them to continue the approach that they have taken. Now with Colorado having its rule, the real space in between is those ERISA non-Colorado DOI plans. Where do their ground ambulances go? And currently there's neither rule applies to them. So there's opportunity there.
Great, thanks. Well, I'm not seeing anything else coming through, though I'm sure if other questions come up, David would be happy to chat with you one-on-one. His contact information is here, and I believe we will have that information. And if it's possible, hopefully a copy of the slides. I know David was making sure we had fresh information, hot off the presses. So we'll provide those too. But thank you so much. We really appreciate you sharing your expertise with us today. I will end this webinar, and just like we have the rest of this morning, we'll have a little bit of a break while we prep all of our other speakers. We will be hearing from the Colorado Hospital Association here at 11 o'clock. You'll use the same link that you've been using. Thank you all for being here, and thank you again, David.
Thank you so much for having me. I really appreciate it.